Good afternoon, everyone. Sorry, we were having a few technical issues with the sound there, but hopefully you can all hear me now. My name is Becky Burbidge. I'm here with Karin O'Sullivan. I'm the Deputy Chief Executive of SPA and Karin's our clinical consultant, and we're here to talk to you today about contraception and problematic bleeding as part of our webinar series brought to you by our Sexwise programme. So once again, sorry about those technical issues, and we'll try and hurry through so that we don't keep you all longer than you had intended to be kept by us. So today we're going to be covering the following. We're going to be talking about why we've actually chosen this topic for a webinar, what we actually mean by problematic bleeding. We're going to run through the different methods of contraception and the bleeding that patients might expect from those methods, and then look at some approaches to handling bleeding if patients are coming back to you and saying that they're not happy with the bleeding that they're experiencing. And then we're going to look at some strategies to manage that. And then we're going to give you a quick update on the latest SPA and Sexwise information and publications. So hopefully you'll find that it's worth sticking with us for that. And just very quickly to let you know, as I mentioned, the webinar is part of our Sexwise programme, which is funded by Public Health England, and it's a national patient resource with information about contraception, pregnancy, STIs and pleasure. I'm sure you all know about it if you're here, but if you by any chance don't know about it, please do go and take a look at sexwise.org.uk. There's lots of resources there for healthcare professionals as well as for patients. So why we're talking about problematic bleeding? A few different reasons really. We know ourselves from our work and from the questions that we get through our Sexwise email that it's something that really concerns women. And we've also spoken to the National Sexual Health Helpline, and it's something that they get a lot of queries about. And what we found is that if bleeding patterns sort of aren't managed properly, and if patients' expectations aren't managed, then it can be really easy for patients just to decide that's it, they're discontinuing with a method that they would otherwise have sort of happily continued with. And so we think it's really important to have strategies to kind of deal with that and ways to manage people's expectations about their bleeding patterns and how they're going to be both in the short term and the long term. And it's something that GPs, when we've been out and about at exhibitions talking to people, have also told us that it's something they'd like more resources on. So this webinar is the first step in that. We're not going to cover every single cause of problematic bleeding and every single solution, but we want to help you work with your patients to sort of manage and define what's going to be acceptable to them. So on that note, I'm going to hand you over to Karin, who's going to start talking you through what we actually mean by problematic bleeding. Thanks very much, Karin.
Hi. So put simply, problematic bleeding is anything that's unacceptable to the patient and their lifestyle. So we might be thinking that with the progesterone methods, irregular bleeding is to be expected, but patients may have very different views from that. So it's really important that we look at what's acceptable to the patient and their lifestyle. And this could include irregular bleeding, breakthrough bleeding, spotting, or heavy bleeding. And again, different people will have different ideas about what's acceptable to them. So something that one person copes with very well and is quite happy about, another person might feel is unacceptable to them and find things very difficult to cope with. So just going to run through the expected bleeding with different methods of contraception. I'm sure that you're aware of these, but I think it's really important when we start talking to women about contraception or looking at which method might suit them, that we're able to give them some idea about how their bleeding patterns may or may not be affected. And certainly the combined hormonal contraception, one of the big advantages of these methods is that bleeds will usually be shorter, lighter and less painful. And so women will often use these methods to control periods or problems with their bleeding. And that's one of the big advantages. But we need to counsel women that in the first 3 months of use, some 20% of users will have irregular bleeding when they're not expecting it. This usually settles beyond 3 months, which is why we will often give women a 3-month supply of contraceptive, a combined hormonal contraceptive method because any bleeding, irregular bleeding that they do have within those first 3 months does usually settle down. And we've also got new guidance from the Faculty of Sexual and Reproductive Health, which is really looking at better usage of the alternative regimes that we have, so extended and flexible use of the combined hormonal contraception. And FPA Sexwise information is currently very close to being completed so that you'll be able to see all that and to be able to order the leaflets, which you can use with patients to explain the extended and flexible use of the combined methods. One of the slight things that we need to talk about with that is that with the extended from flexible use, that continuous use can cause some unpredictable breakthrough bleeding. But again, there's ways of managing this, so it's really great to be able to look at the information that's out there and to use that with patients to explain how to manage any unpredictable bleeding that they may have. I'm sure that you're all very aware that any of the progesterone methods of contraception, bleeding can well be irregular, unpredictable, may settle to no bleeding. So we'll start with the progesterone pill. Periods may be lighter or stop, and for the first 3 months, as with the combined hormonal methods, bleeding can be unpredictable. However, with the progesterone methods, the bleeding may not settle with time. So women may continue to have irregular or lighter bleeding. After 3 months, frequent and irregular bleeding are still common. So it's one of the slight disadvantages of a progesterone method is that you can't always predict when your bleeding will happen. With the injection, periods may be lighter or stop, and the first 3 months, again, bleeding is unpredictable. 1 in 10 women will stop having bleeds, and this increases as the women continue on the method. So with the longer use, the rates of users not having bleeds increases. And usually I would counsel women that by the time they've had 3 injections, most women are not having bleeds. So that's really helpful for women to know so that they can think more long term. With the implant, again, it's a progesterone method, so periods may become irregular. And again, the first 3 months, bleeding is unpredictable. I often draw a chart for women, a little picture for women when I'm talking about the implant. So the hormone levels with the implant are higher for the first 3 to 6 months of usage, and then they drop down to the level that they're going to remain at pretty much for the next 3 years. So I think it really helps to draw this little picture and then be able to explain to women why the bleeding can be more problematic at the beginning and why it will settle down. And again, 1 in 10 women will stop having periods, and over longer usage, again, similar to the other progesterone methods, longer usage, women not having bleeds increases, so the rates of amenorrhea do increase. But really, it's about supporting women over that first 3 to 6 months where the most irregular bleeding takes place. And we used to say to people, that's common, it's going to happen, go away, put up with it. But that's not very helpful. So much of the advice nowadays is that if women are expecting irregular bleeding, that's fine. But if they're finding that it's unacceptable for them, come back and see us sooner, because we can often do something that will help. And sometimes it's just about buying time, enabling that woman to feel that she's listened to and that we are helping and not ignoring her, so that we can get over this first 3 to 6 months, which may be more problematic than the next 2.5 years. So I think it's really important to have an open door policy, to invite people to come back, to listen, and to help them with treatment that will help regulate bleeding over that time if we can. So the intrauterine systems, we've got several different devices now coming out onto the market. Again, it's a progesterone method, so periods usually lighter, but can become irregular. And again, the first 3 months, frequent bleeding, spotting is common. Bleeding does decrease over time with either dose, but the higher dose, the IUS Mirena, is licensed for, and Levocert are both licensed for use with heavy menstrual bleeding. And so these have a much higher rate of people with no bleeding over a longer length of time, and are part of the NICE guidance on treatment for heavy menstrual bleeding. So again, counsel women that if bleeding is problematic, this might well be a really good answer to that and their contraception needs. IUD, this is copper, and can lead to an increase in bleeding, heavy or more painful. But this does decrease over time. So again, sometimes we need to just say this is likely to happen in the first 3 months. If that's not acceptable to you, then maybe think about an IUS instead. But if you think that you're okay with that, then it should get better over time. Then let's give women the information so that they can make better decisions based on that information. So how do we look at talking to women as clinicians? One of the first things that we should do is to check out the patient's own concerns. How much bleeding is happening? Is it frequent, infrequent, prolonged, spotting, breakthrough bleeding? And how does it affect their life? For example, you could ask, does your bleeding affect your daily life? Do you have to organise your social activities around your bleeding? Are you concerned about accidents? And for some people partaking in religious festivals or practices, if they're bleeding, it means that they can't participate. So that, again, is something that might affect their daily life and would be really important to consider. We do need to look at clinical history. So once we've ascertained that any bleeding could potentially be a problem for the patient in front of us, think about the method of contraception, how long they've used it. So we've already talked about the first 3 months, things settle down generally. So if this is something that's a new method of contraception, then it's more to be expected than if they've been using it for some time. Are they using the method correctly? So for the methods with the user failure, so the higher the combined pill, the progesterone pill, are they late for their depot injection? If missing pills or late for their injection, that could explain why bleeding has come back or there is any breakthrough bleeding. Are they using any medicines that interact? So again, any medicines that you're taking that have been prescribed or over-the-counter medicines or herbal remedies? Or do they have any illnesses which may affect absorption? A bout of severe diarrhea or vomiting, if you're using some of the oral contraception, may mean that your combined hormonal contraception or progesterone only contraception is not being absorbed properly, and then again you could get problems with the breakthrough bleeding. Think about other things: cervical screening history, risk of STIs, bleeding patterns since starting hormonal contraception and currently, any other symptoms which might suggest an underlying cause, and be aware of the possibility of pregnancy if methods of contraception are not being used effectively. And there is obviously nothing is 100%, so there is always that possibility which should be in the back of your mind. Sexually transmitted infections. Everybody using hormonal contraception with problematic bleeding should be assessed for risk of STIs, and this means taking a sexual history. So it's really important to look at risk factors. We all know that chlamydia, for example, is much higher in the under 25s. So you can, of course, get chlamydia if you're an older person, older, more than 25 years old. Wow, I'm ancient. But think about new sexual partners in the last year and asking people about sexual history. Chlamydia can cause problematic bleeding, so one of the minimum tests that we should be offering is a self-taken swab for chlamydia, and this will check for gonorrhea as well. But it's really important to discuss the sexual history with people so that they can be aware of any tests or investigations that would be helpful. Cervical screening. This is not a tool for diagnosing irregular bleeding, but it's important to check that a contraception user has been participating in the cervical screening program. So that's for over 25. And if a screen is overdue or due, then it can be done, but should not be taken because of problematic bleeding issues. STI screen is much more important, and the guidance backs that up. So by all means, ask about cervical screening, and as I've said, if smear screen is due or overdue, then take it. It also gives you, it's a good idea to have a look in the vagina at this to check for anything like polyps or cervical erosion, anything that you might notice inside. But do not take this unless they are due, because they're not a diagnosis tool. As we've mentioned, pregnancy test. If there is a possibility of pregnancy, got bleeding, then it's always worthwhile. But think about time frames again. So pregnancy test will not be accurate sooner than 3 weeks after the last unprotected sex that you're concerned about, or the last episode time frames. So do think about doing a pregnancy test, but if it's negative, then it should be repeated. And again, sexual history of when the last sex was, when the last regular bleeds, if the person is having regular bleeds, and recheck the pregnancy test if that's required or doesn't fit in quite with the history. So a negative test may be a false negative rather if it's done too soon. So do think about that. So clinical examination I've talked about a little bit already, but if you haven't had a look initially, then think about if the bleeding persists beyond the first of use, if there's any new symptoms or change in bleeding after 3 months. If the patient requests it, really reassured if you had a look, please, doctor or nurse, is it okay if I examine you? Sometimes that can be helpful. So elicit that permission and make the offer if the patient wants that. Any other symptoms, so pain, dyspareunia, postcoital bleeding, it could be really important to examine the patient and just check that there's nothing that you're missing. Red flags, women over the age of 45 or younger with risk factors, pain or pressure symptoms. What we're looking for is risks of endometrial or ovarian cancer. These are hidden cancers. We don't have screening programs for them, so always be aware that that could be a possibility. Have that in the back of your mind. You don't want to miss anything. So how can you help your patients to manage the problematic bleeding? Many women don't feel confident talking about their period problems, so it's something that you should encourage people to talk about. Ask the questions, and then they'll know that you're somebody that they can come and talk to about. People may not realise that their experience isn't normal, or may feel too embarrassed. And if patients are reported, as Becky said earlier, there is a risk that they will discontinue the method of contraception and end up using less effective or no contraception. So it's such a shame that a method of contraception could work for someone, but because they haven't been able to talk about their concerns or worries, that they give up on it. So that's why have an open door policy. Encourage women to come back and talk to you about any side effects or concerns that they may have. Listen to the concerns. It's important that patients feel you've taken them seriously and not just said, oh, it will settle down. This is quite normal, the first 3 months, absolutely fine. It will settle down. take the time to actually listen to women. Go back to those questions that we had about, does this affect your daily life? Does it cause problems for you? Are you finding it difficult to manage? And just being aware that somebody is listening to them can often help. Reassure that period problems are very common and that it is normal to affect physical, social and psychological health and well-being. But again, if you listen and try and problem solve with the patient, that's often sufficient that people feel listened to and more understanding of how the methods of contraception work and the likely bleeding potential. Help patients to weigh up the advantages and benefits of the method. So we've already talked about hormonal contraception makes bleeds regular, lighter, shorter, and less painful. So there are advantages: protection from cancer of the ovary, protection of cancer from the ovary, womb, and colon with the combined hormonal contraception. So talk about all the benefits as well. And that can be then weighed against any issues that they feel bleeding is causing. So any issues that might be causing a problem, then that can be weighed up against the advantages of the method of contraception in preventing pregnancy. It's worth also talking about associated symptoms, but be aware that things like tiredness, bowel and urinary problems might not be related. So encourage patients to keep a diary or a chart listing any symptoms. There are tracking apps that can do this if they prefer a digital solution, or I used to give people a menstrual chart, a small A5 piece of paper with 3 or 4 months of calendar months that they could colour in the boxes when they had any bleeding and write any associated symptoms down. And that was always really helpful, because sometimes women will find that the bleeding, that they're actually having less bleeding than they thought when they start to complete the chart. Give information so that patients know what to expect and manage the expectations. It's really important to say again that bleeding does typically decrease over time. Women might not be so aware that things will settle down, but that piece of information may have been missed in the initial consultation. So reiterate it and explain it. Draw the picture of the hormone levels with the implant. And as I've said, patients know that they can come back and talk to you if they need it. And then if it remain unacceptable, considering a different medical approach. So there are different types of medical treatments that we can try and use, and that's really important in the it's noted in the Faculty of Sexual and Reproductive Health, which we've got a reference for in a moment. I think I'm handing back to Becky now.
Yeah, hi everyone, and thank you, Karin, for that brilliant overview. I hope you found that useful. So there's a quick chance for you to ask some questions now. So due to our technical problems earlier, we're running ever so slightly over, but we'll just open up the questions for 5 minutes or so, and then I'm just going to run you through some references and some updates to FPA's information. Just trying to get the questions box to come up for you. Beset by technical issues today. Okay. Right, you should find that there's a box in the left-hand corner where you can ask your questions, and we'll try and take a few questions, but what we'll do, if you submit your questions as well, then we'll send you written answers to those. Okay, let's just see if there's any questions go through. So we've just got a question about whether there'll be access to after the webinar. as someone was having problem seeing slides. Apologies if anyone else has had trouble seeing the, or if you were maybe just listening and not able to see the slides, but yes, we'll have a recording of the webinar and we'll make the slides available afterwards to everyone who's registered. So that's one question. Just while we're waiting to see if any more questions are coming up, I'll just quickly, just going to quickly run you through the resource and extra resources. So if you want to get more information about problematic bleeding and contraception, particularly around sort of medical treatments as well, which we haven't gone into in this webinar, then the Faculty of Sexual and Reproductive Healthcare have a really useful guideline. Again, we can send around these links after the webinar, but it's well worth checking that out. And the Royal College of Obstetricians and Gynecologists also have a menstrual, oh, that's spelled wrong, I see, menstrual wellbeing toolkit, as we say here, which is, again, well worth checking out. And I just wanted to flag up as well some quick updates to FPA's information and publications. So we, as Karin mentioned earlier, Faculty of Sexual and Reproductive Healthcare have recently released new guidance on combined hormonal contraception, where it talks much more about the use of flexible and extended use and how patients can do that. So we're updating all our patient information to reflect that guidance. So our Sexwise website's being updated this week, so you'll be able to direct patients to that for the very latest evidence-based information. And FPA's printed leaflets are also being updated, and they'll be available to download as PDFs and to order from our shop very soon indeed. And just to flag up as well some changes. You may or may not be aware that the British Association of Sexual Health and HIV have their gonorrhea guidelines, so we're also updating our patient information to reflect that, and that will be updated on Sexwise and also be updated in the form of a leaflet that you can order from our shop. And just to flag up, if you don't already get them, don't forget to sign up for Sexwise's emails, and then we can alert you when we do have any new resources and when there's any new webinars scheduled. So we're just coming up to 2:05, so we'll just keep the webinar running for another few minutes. And I think we've got time to take one or two questions. So I'm going to hand you over to Karin now, just to answer a couple of the questions that we've had come through. Do please keep the questions coming through if you want to, because if we don't have time to answer them, we can send around written answers later on. Okay, thanks. Over to Karin.
Hi. Couple of this is about the bleeding pattern for implants settling after 3 months. So as stated earlier, if you have a look at the summary of product characteristics for Nexplanon, it does talk about the higher levels of hormones, and it does talk about the evidence that as these settle to the level they're going to be at for the next 3 years, that the bleeding does settle. That's also backed up in the faculty guidance on implants, so have a look at both of those references. Can you give us an example of how you might manage a patient with persistent light intermittent bleeding on Mirena beyond 3 to 4 with no obvious underlying causes? When and how to start an additional POP or combined oral contraceptive pill? So I again would direct you to the Faculty of Sexual and Reproductive Health problematic bleeding with hormonal contraception guidance to look at that. There's a very useful flow chart in there. If people can use the combined hormonal contraception, then it is worth trying combined oral contraception pills for 3 months, continuous usage rather than stopping at the 21/7 regime. If they can't use the combined oral contraception, the evidence base for using additional POPs or something like mefenamic acid, tranexamic acid isn't good, but it's worth looking at. So I would direct you to look at the faculty guidance and follow that. And I'm going to hand back to Becky for the last question, which is about apps.
to bleeding and contraception. The simple answer at the moment is no, we don't endorse any specific products, and we're not really able to do that, unfortunately. There's so many apps sort of out there, and the app market's kind of so unregulated that it's really hard for us to kind of review and make recommendations on that kind of area, unfortunately. It's possibly something we might be able to look into in the future, and if we do, then we would kind of post that information on Sexwise, and it probably wouldn't be an endorsement, it would more be a list of the ones that we kind of felt were better or not. But yeah, so apologies not to be able to help a bit further with that one. So it's it for the questions, and we've just been running for half an hour. So I'm going to let you go back to your day now. Once again, thank you so much for giving up some of your lunchtime to join us. Many apologies for the slight technical issues we've had today. We're broadcasting from a different venue, and we're not used to it, so thank you for sticking with us. We really appreciate it. Our next webinar is in March, and it's going to be on hot topics in sexual health. I hope you'll be able to join us for that one. If you've not already registered, then just pop over to the Sexwise website and the professionals page, and you'll be able to get the details on that. And we hope that we'll do that one with a few less technical issues. Just to flag up as well that we run a training course on contraception. Well, we run a couple actually, so we've got a 2-day course coming up in March, and also we run the Faculty of Sexual and Reproductive Health training course every day. SRH Essentials, Karin has just told me, thank you. So details of all those courses on the FPA website, fpa.org.uk training. So once again, thank you very much. We'll send you details through within the next week or so of how to access the slides. You'll also get a certificate of attendance if you've stuck with us for more than 15 minutes. And we welcome your feedback so that we can improve in future. So once I end the event in a minute, you should have a little thing that pops up where you can rate it. Ideally, if you could rate it on the content rather than the technical issues, that would be great, because that would really help us kind of improve in the future. So thank you very much, everyone, and hopefully see you all soon. All right, thanks, bye.